Drugs used in the treatment of disorders of respiratory system. Bronchodilators. These are bronchodilators medication used to facilitate respiration by dilating the airways. They are helpful in symptomatic relief or prevention of bronchial asthma and bronchospasm associated with COPD. The bronchodilators are xanthines, sympathomimetics, beta agonists, anticholinergics, inhaled steroids. Xanthines. Xanthines, including caffeine and theophylline, come from a variety of naturally occurring sources. These drugs were one's main choice for treatment of asthma and bronchospasm. The xanthines include aminophyline, caffeine, theophylline, oxytryphyline, pentoxyphyllin, theophylline. Pharmacodynamics, drug action. The xanthines have a direct effect on the smooth muscles of the respiratory tract, both those on the bronchi and the blood vessels. The xanthines stimulate the CNS such that respiration is stimulated, coronary arteries dilate and pulmonary arteries dilate, with additional effect of diuresis. Clinical use of the xanthines. Xanthines are indicated for the symptomatic relief or prevention of bronchial asthma and reversal of bronchospasm associated with COPD. Unlabeled uses include stimulation of respiration in Cheyne-Stokes respiration and the treatment of apnea and bradycardia in premature infants. Pharmacodynamics, drug side effects. GI upset, anorexia, vomiting, gastric pain, nausea, irritability, and tachycardia to seizures, brain damage, and even death. Theophylline toxicity occurs when concentration is above 20 ml. Rapid administration of aminophyline can cause dizziness, flushing, severe hypotension, bradycardia and palpitations. Nursing responsibilities. Monitor vital signs and note for the BP and HR because there may be hypotension and tachycardia. Administer oral drug with food or milk to relieve GI irritation, if GI upset is a problem. Monitor patient response to the drug is equal to relief of respiratory difficulty and improved airflow, to determine the effectiveness of the drug dosage and to adjust dosage as needed. Provide comfort measures, including rest periods, quiet environment, dietary control of caffeine, and headache therapy as needed, to help the patient cope with the effects of drug therapy. Provide adequate hydration. Don't crush enteric-coated and sustained-release tablets. Encourage to stop smoking. Provide periodic follow-up including blood tests to monitor serum theophylline levels. Evaluation. Monitor patient response to the drug, improved airflow, ease of respirations. Monitor for adverse effects, CNS effects, cardiac arrhythmias, GI upset, local irritation. Sympathomimetics, beta-2 adrenergic receptor agonists. Albuterol, levobuterol, metoprolol, terbutaline, salmeterol, and formoterol. Short-acting, albuterol, levobuterol, metoprolol, terbutaline. Long-acting, salmeterol, formoterol. Mechanism of action. Beta-2 adrenergic receptor agonists relax bronchial smooth muscle, thereby reversing bronchoconstriction. They do not significantly decrease the bronchial hyporesponsiveness or the primary inflammatory reactions responsible for the persistence of asthma. Uses. Short-acting agents act rapidly to provide symptomatic relief of acute asthma symptoms. Long-acting agents are used to treat asthma that is not well controlled by corticosteroids alone. These drugs form the cornerstone of bronchodilation therapy in COPD, often in combination with an anticholinergic drug. Side effects. Tremor, anxiety, and restlessness. Anticholinergic drugs. Ipratropium, oxytropium, and tiotropium. Mechanism of action. Anticholinergic drugs produce bronchodilation by blocking the bronchoconstrictive effects of acetylcholine acting on muscarinic receptors on bronchial smooth muscle. They have the further advantage of reducing mucus production by inhibiting vagal stimulation of goblet cells. Uses. These drugs have limited efficacy in asthma but are useful add-ons to beta-2 agonists in moderate to severe COPD. Side effects. dry mouth, blurred vision, tachycardia, urinary retention, and constipation. Corticosteroids: budesonide, cyclophosphamide, flunisolide, fluticasone, mometasone, beclomethasone, and triamaquinolone. Mechanism of action: these anti-inflammatory agents decrease bronchial hyporeactivity and the formation of mucus. They are the most effective anti-asthmatic drugs available. Pharmacokinetics: these agents are inhaled through metered dose inhalers or dry powder inhalers. In severe persistent asthma, they may be given orally. In asthma emergencies, status asthmaticus, they may be given intravenously. 4. They should be used at the lowest dose that provides adequate control of symptoms. Uses: moderate to severe asthma. Corticosteroids are generally not used in COPD patients unless bronchodilation cannot be achieved with beta-2 adrenergic receptor agonists and anticholinergic drugs. Side effects: throat irritation and dysphonia, speech impairment and hoarseness, may limit compliance. Oral candidiasis, thrush, is possible as a result of inhibition of normal host defenses. The chances of developing thrush may be reduced by using spacer devices with the inhaler, rinsing the mouth after use of the inhaler, and/or decreasing the steroid dosing frequency. Endocrine effects have rarely been reported, but the growth of children should be monitored to ensure there is no suppression of the hypothalamic pituitary axis. High doses inhaled or long-term systemic corticosteroid therapy for refractory asthma can lead to a Cushing-like response. Antitussives: these are agents suppress the cough reflex on the medulla oblongata to suppress cough of many respiratory conditions. The antitussives are the following: benzonatate, narcotic antitussive; butamiryate citrate, non-narcotic; codeine, narcotic; dextromethorphan, non-narcotic; hydrocodone, narcotic. Pharmacodynamics: therapeutic use of the antitussives. The traditional antitussives act directly on the medullary cough center of the brain to depress the cough reflex, but it does not suppress respiration. Dextromethorphan does not depress respiration. Clinical use of the antitussive. Utilized for the treatment of cough. Contraindications and indications for use of antitussives. These agents are not given to patients who have undergone thoracic and abdominal surgeries because they need to cough to maintain airway patency. Precautions are instituted when giving to patients with asthma, emphysema or COPD because an accumulation of secretions may occur. Pharmacodynamics, drug effects. Respiratory, dryness of mucosal membranes, increased viscosity of secretions. CNS, drowsiness, dizziness and sedation. Get, nausea, constipation and dry mouth, get upset. Nursing process and the antitussives. Implementation. Emphasize that the drug should be taken only on a specified time frame as ordered. Provide other measures to relieve cough like provide humidified oxygen, cool temperatures, fluids and use of lozenges. Provide health teaching as to drug name, dosage and measures to handle side effects. Caution that alcohol, narcotics, sedatives, hypnotics can cause CNS depression when used with antitussives. Expectorants. Expectorants facilitate the removal of fluids from the lungs. Guaifenesin. Mechanism of action. Guaifenesin increases the volume and reduces the viscosity of bronchial secretions. This may make it easier for coughing to remove the secretions, but the effectiveness to reduce cough is questionable. Pharmacokinetics. Given orally. Uses. Although guaifenesin is found in over-the-counter medicines, its effectiveness in cough and colds is controversial. Its only approved use is to loosen phlegm in patients forming an abnormal amount of sputum, chronic bronchitis, but this usage is also of questionable efficacy. Mucolytics. These are agents that break down mucus in order to help respiratory patients in coughing up thick, tenacious secretions. The following are the mucolytics. Acetylcysteine. Dornus alpha. Pharmacodynamics, mechanism of action. These agents work in the following ways: Acetylcysteine affects the mucoproteins in the respiratory secretions by splitting apart disulfide bonds that are responsible for holding the mucous materials together. Cautions should be used in cases of acute bronchospasms, peptic ulcer and esophageal varices. The increased secretions can aggravate the problem. Indications for use: COPD, cystic fibrosis, pneumonia, tuberculosis, atelectasis. Pharmacodynamics, drug effects. GIT, GI upset, stomatitis, irritation of the respiratory tract. Others, bronchospasm and rash. Implementation: instruct the patient to avoid combining with other drugs in the nebulizer to avoid formation of precipitates. The drug can be administered via nebulizers with the drug diluted with sterile water. Remind the patient that the drug may irritate the respiratory mucosa. Provide through patient teaching including drug name and prescribed dosage. Have suction machine available. To treat acetaminophen overdose. Antihistamines, also called H1 blockers or H1 antagonists, these are agents designed to relieve respiratory symptoms and to treat allergic condition. The antihistamines are grouped according to the generation. The first generation agents have greater anticholinergic effects and can cause more sedation and drowsiness. These agents cause drowsiness: azithromycin, dimenhydrinate, acelastine, diphenhydramine, brompheniramine, hydroxygenate, buclizine, meclizine, cetirizine, methylzine, chlorpheniramine, promethazine, clemastine, triplenamine, cyclizine, carbinoxamine, cyproheptadine, trimiprazine, dexchlorpheniramine, triprolidine. The second generation agents have fewer anticholinergic effects, that is why they cause less sedation. Fexofenadine, loratadine, acelastine, levocetirizine. The mechanism of action: these agents selectively block the effects of histamine at the histamine 1 receptor sites in the target tissue by competing with histamine 4 receptor, decreasing the cellular responses. They also have anticholinergic and antipruritic properties. Clinical indications for use in respiratory system: rhinitis, allergic sinusitis, uncomplicated urticaria and angioedema. Contraindications and precautions for the use of the antihistamines: pregnancy and lactation are contraindications, and the agents are used cautiously in patients with impaired liver and kidney functions. Fatal arrhythmias have been reported if some of these agents are given to patients with a condition called prolonged QT intervals. Pharmacodynamics, drug effects on the body: CNS, drowsiness and sedation, most pronounced if first-generation agents are used. Fatigue, dizziness and disturbed coordination. Anticholinergic effects: drying of the respiratory mucous membrane, GI upset and nausea, arrhythmias, dysuria, urinary retention, skin dryness. Implementation: the nurse should administer the drug on an empty stomach, or 1 hour before or 2 hours after meals to increase the absorption. Give with food if GI upset occurs. Offer sugarless lozenges or hard candy to counteract dryness of the mouth. Give frequent oral care. Provide safety measures if drowsiness may occur. Side rails up, assist in ambulation, and advise not to drive or operate dangerous machineries or delicate tasks. Increase humidity in the room by utilizing nebulizers and provide adequate hydration. Allow the patient to void first before administering the drug. Caution the patient against use of OTC drugs, alcoholic beverages and sedatives because they may cause extreme sedation. Evaluation: monitor patient's response to the drug, the adverse effects and the effectiveness of comfort measures employed. Decreased allergic symptoms. Decreased occurrence of rhinitis. Leukotriene modifiers. Leukotrienes are potent bronchoconstrictors produced by cells involved in inflammatory responses, including mast cells and eosinophils. Montelukast, zafirlukast, and gileotone. Mechanisms of action: Montelukast and zafirlukast are leukotriene receptor antagonists. They bind with high affinity to the cysteanyl leukotriene receptor 1, CYS lieutenant 1, receptor, blocking the effects of the cysteanyl leukotrienes, LTC4, LTD4, and LTE4. Gileotone is a leukotriene synthesis inhibitor. It inhibits the enzyme lipoxygenase and thus inhibits the formation of all lipoxygenase products, including the CYS-LTS and non-CYS-LTS. Cysteine leukotriene synthesis can be blocked by inhibiting lipoxygenase, the enzyme responsible for converting arachidonic acid to leukotrienes. This can be achieved by drugs such as gileotone. Montelukast, on the other hand, blocks leukotriene receptors on target tissues. Pharmacokinetics. These drugs are administered orally and are well absorbed. Uses: prophylaxis of asthma, allergic rhinitis. Side effects: some patients experience headache with these drugs, otherwise, they are well tolerated. Mast cell stabilizers: cromolyn sodium and nedocromyl. Mechanism of action: cromolyn sodium inhibits mast cell degranulation and other allergy mediators by blocking Ca2+ channels in the cell membrane. This causes a reduction of bronchial hyporesponsiveness. Uses: prophylaxis of asthma. It is not a bronchodilator and is of no use in acute asthma. It is not as effective as corticosteroids, but it has an excellent safety profile. Allergic rhinitis. These agents are administered intranasally several times a day for the symptomatic treatment of allergic rhinitis. Side effects. The side effects associated with cromolyn sodium are minimal. Decongestants: phenylephrine, oxymetazoline, naphazoline, pseudoephedrine, and phenylephrine. Intranasal decongestants: phenylephrine, oxymetazoline, naphazoline. Oral decongestants: pseudoephedrine, phenylephrine. Mechanism of action: decongestants are sympathomimetics that decrease nasal blood flow by activating alpha-1 adrenergic receptors. Pharmacokinetics: intranasal agents have a more rapid onset of action and produce fewer systemic effects than oral agents, but oral agents have a longer duration of action. Uses: symptomatic treatment of rhinitis. Side effects: oral decongestants can cause systemic effects, such as central nervous system, CNS, stimulation, tachycardia, hypertension, and urinary retention. Rebound nasal congestion may occur upon withdrawal of the drug if used for more than 5 days. This is more common with intranasal agents. Cromolyn and nedocromyl inhibit mast cell degranulation of histamine and other allergy mediators by blocking Ca2+ channels in the cell membrane. Nedocromyl also has an anti-inflammatory effect by inhibiting chemotaxis and migration of inflammatory cells. Alpha sympathomimetics are given by nasal spray or drops to reduce nasal swelling and congestion. Contraindications: hypertension, coronary artery disease, or in patients on monoamine oxidase inhibitors, MAOIs. Anti-immunoglobulin E antibody. Omalizumab. Mechanism of action: omalizumab is a recombinant humanized monoclonal antibody directed against IgE that binds free IgE. This prevents IgE from binding to mast cells and basophils, thereby inhibiting IgE-dependent hypersensitivity reactions to allergens. Pharmacokinetics: given by subcutaneous injection, every 2 to 4 weeks. Uses: omalizumab is generally reserved for use in patients with severe, persistent, IgE-mediated allergic asthma who are inadequately controlled with the other medications discussed above. It has also been proposed for use in other type I allergic reactions. Alpha-1 proteinase inhibitors. Prolastin trademark symbol, Zemera trademark symbol, and Aralast trademark symbol. Note: there are no generic names for this type of drug. Mechanism of action: these agents are alpha-1 antitrypsin products that are derived from the plasma of blood donors. Pharmacokinetics: given for on a weekly basis. Uses: indicated for patients with Panasina emphysema who have alpha-1 antitrypsin deficiency. Surfactant: Baractant. Mechanism of action. Baractant is a modified bovine lung extract, a natural surfactant, and colfoseryl is a synthetic surfactant. Pharmacokinetics. These agents are given by tracheal instillation. Uses. Used to modulate neonatal respiratory distress syndrome. Pulmonary surfactant. Pulmonary surfactants are lipoproteins produced by alveolar cells, type 2 pneumocytes, starting at around 24 to 28 weeks gestation. By week 35, most babies have developed an adequate amount. Surfactant acts to reduce the surface tension of the lung, thus increasing compliance, the ability of the lungs to stretch when pressure is applied, and preventing atelectasis, collapsing of the lung, at the end of expiration. Premature neonates born before lung maturation can be given steroids to promote type 2 pneumocyte differentiation and the production of surfactant. Test for fetal lung maturity. Fetal lung maturity can be tested by extracting a sample of amniotic fluid and measuring the lecithin sphingomyelin ratio, LS ratio. A LS ratio less than 2:1 indicates surfactant deficiency and therefore lung immaturity.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.